Hello and welcome to this video which provides fatty lumps guidance for diabetes professionals. We do hope that you enjoy it and find it useful. If you have any feedback, please do share it in the comments section, and please make sure that you like the video and subscribe to our channel so that you don't miss any new content that we upload. Hello, my name is Hope Frost, and on behalf of SBK Healthcare, I'm delighted to welcome you to this webinar on fatty lumps guidance for diabetes professionals. Firstly, I would like to thank Sanofi and BD for kindly sponsoring this webinar. Now it is my pleasure to introduce your webinar leader, Georgina Doyle. Georgina is an advanced nurse practitioner in diabetes from Midland Regional Hospital Portlaoise. Hi, Georgina.
Hi everybody, so I've been invited today to do this webinar on fatty lumps or lipohypertrophy. So I am an advanced nurse practitioner in diabetes and I am based here in Midland Regional Hospital Portlaoise. I work as a team, there's myself and the AMP. We have two CNSs, one CMS, senior podiatrist, 2 senior dietitians and 3 consultants, and around 7,000 patients. We're a small centre, I suppose, compared to a lot of centres out there. So I suppose the area of lipohypertrophy is an area that I am hugely interested in. I think it is so essential to our practice, and it, even for ourselves as healthcare professionals, our learning constantly, as you all know, constantly needs to be updated, and for our patients, and it's for us to pass on this information to our patients. So the learning outcomes of today's webinar for me, that I kind of felt that I wanted to share with you guys, is just the importance of injection sites, choosing the sites, the needle length and size, managing erratic blood glucose levels. I mean, I'm sure you've all seen that if you've got patients with lipohypertrophy, giving some advice to your patients when they have lipohypertrophy, and then hypo and hyperglycemia. So this diabetes bubble, this is quite a busy slide, and I put this in here because it's all really relevant to diabetes. Every word on that is all, diabetes related, and it's mostly, I suppose, in a way, it's all kind of the side effects of diabetes. It's like there's so much to do with diabetes, and there's, as healthcare professionals, I'm sure you all know, like all of this is just so relevant. But there's one thing in this that this bubble doesn't have. It doesn't have a word for it, and it doesn't say anything about injection sites. Now, I did have a good look, but you might find some more, but I don't see anywhere. It just is like, hyperglycemia, hypoglycemic, glucose, worries, blindness, all of those things. So it's just like, we need to kind of, I suppose, highlight that in our practice. As I was saying, injection technique, site rotation, lipohypertrophy, like the injection technique, really for me, it's one of the core aspects of my diabetes practice, and it's something that I would discuss with my patients on a daily basis. Obviously, the times that we're in, a lot of your clinics like my own are probably virtual. You're doing phone calls, Zoom calls, trying to teach people. People are starting insulin. It's been a particularly tough time. We've all been really busy, and just to help our patients through. So you all know what lipohypertrophy is, and as healthcare professionals, it's something that we do see quite regularly, and I don't need to I'm sure you're all very aware of these pictures, and what it is and what it represents. And like, for me to keep up to date in my practice and to make sure that my practice is evidence-based, it's constantly searching the literature, looking what trials are out there, what papers have been written, what resources are available to me that I can then pass on to my patients. And I strive to address this at every review that I can, be it virtually, like over the telephone, or if it's a patient that comes in to me. I suppose the virtual, it's been a little bit more difficult, because adjustments, you try to make these adjustments, you try to incorporate all your diabetes care into one kind of call, and you've so much to cover because there could be so much going on with that patient, and it can be very easy to get sidetracked from actually injection sites. So it's kind of, we have developed a document here in Portlaoise that we use in our clinics and at our reviews, and it's an MDT document. So each team has part to write on, but it's in the first few pages, it literally follows the diabetes model of care that we use here in Ireland, and in that is we have a page dedicated to to injection site rotation, needle length, reusing needles. Sorry, I'm looking at it now just in case I forget. Making sure our patients are single use, and we've drawn out 2 body maps on it. And then we mark our sites of if there's any evidence of lipohypertrophy, because it's really important for us to document this in the patient's notes moving forward, so that when you come to review this patient again, at least you've had an idea of if they have suffered with lipohypertrophy, or how things have been going. That's really important. I know these 2 pictures, these are just 2 that I randomly picked. I'm sure you're, again, as healthcare professionals, you guys have seen this so much, but it'd be amazed at the amount of patients that actually don't know what it is, and they just think it's normal. And this is despite, I suppose, and I'm basing a lot of this today on what I do in my practice. And I educate about injection sites and rotation and everything from day one, from diagnosis. And it's, as I say, I just strive to incorporate this into every single review that I have with the patient. But I have found that my patients still come in with lipohypertrophy, some very slight and some that little bit more. So it's important that we get this across to our patients as healthcare professionals, that we can support them, because we can educate them, because education is empowerment for our patients, and that's what we want to do. Like, when you see these pictures at clinic, it's very easy for us as healthcare professionals to say, oh yeah, look, that's your blood sugar is erratic because you have these lumps. And then you start to explain to it, and some patients will be like, oh yeah, I kind of knew. And then there's others that will say to you, oh, I never realized, because there is so much for diabetes patients take on board, but they're a good indicator. We want our patients, I suppose, to become self-care managers. We want them to be empowered to be able to make the changes, to know that they have to move around their sites, or they're going to get these lumps. And we also need to create peer-to-peer awareness. It's very important. Us as a diabetes group here, we would always kind of discuss it, and kind of, if any of the new stuff comes out, we're led by the FIT guidelines. It's the FIT form for injection technique, and it's diabetes care in Ireland. I know there's one for the UK as well. So I suppose as healthcare professionals, we need to ask the right questions, physically check the site if you can. When your patient comes in, it's really important that you actually do that physical checking of it. Talk the patient through the process if it's a virtual, and kind of have the time to spend with the patient to do that. And then to help to speak to the patient, like what to do if you do detect lipo, and then what do you do to prevent it. And it's all very relevant to everyday practice. So I've put in some slides. Next, kind of, I think it's 4 slides. Just talk about, this is the Blanco et al. Study. And these are part of the evidence base that I help guide me in my practice, and my learning as well. They're all based on the FITR guidelines as well. They highlight that by optimizing your injection technique and avoiding injecting into lipos, that it results in clinically significant better health outcomes for our patients, which is really where we want to go. And what was quite shocking for me about when I first kind of looked at this slide a little while ago is 70% of our patients reuse needles, and then 2/3 of insulin users have lipos. That's quite a high number. And for me, in one way, it's hard kind of to say, oh God, I didn't think it was going to be so much, because I educate about this all the time. But then I had to take the seat back and go, you know what, when you look and you go back to your diabetes bubble, there's so much going on. And that's just diabetes. That's not incorporating what happens in life outside diabetes, because sometimes diabetes might not be the biggest problem. And, again, as healthcare professionals, we need to be able to recognize that and to help our patients through. So the Blanco study, and then it's followed up, there's 13 patients that were involved in it, and it's interesting reading. This is what we're based on, and then these are 3 other supporting studies, and they all show that your insulin use and your A1C will fall once you're not injecting into lipos, and that avoiding them results in your significant health outcomes in patients, improving them. This slide, this is a line that I kind of use. How you inject is as important as what you inject. And kind of, if you think about that for a little while, it is, people have, you teach them, your 90-degree angle, going in nice and gently, and it's a good slide to reflect on, and it's good to use it with your patients as well. I find if I say to them, how do you inject, and they're like, oh, I just inject. But if you take them through injection technique, maybe obviously not after diagnosis, but as years go on and months go on, and it's amazing the amount of patients that maybe don't do the 90-degree angle. Maybe they reuse their needles. Maybe they're using the wrong size needle. There's so many elements and factors that do factor into this. So moving on to injection site rotation. Now I know you guys, you're all experts in this area. Injection site rotation it's core. It's a core essence. And BD have this lovely slide. I really like this slide. And actually, I should just say that, although this slide and some more slides are from BD, BD in any way haven't asked me to promote these slides. This is what I use in my daily practice. It's your choice what you would like to use, but this is what I find. I think it's a really good, it's a really good visual. It's clear, it's concise, it's eye-catching, because you can talk to your patients and you can talk and talk and talk, but sometimes all that information doesn't actually go in. Whereas if you show them something visual, then it can actually get them to think, and it gets them involved in selecting their injection sites. That's something that I like to do, I suppose, with my practice. Now in Ireland, we don't use the upper arms. I suppose if you are completely out of injection sites, then it is an option, but we don't really. And I suppose in an area too that I myself would need more and more education from, because we use the abdomen, the thighs, the buttocks, the flanks. And it's like you're advising your patients not to inject into muscle. And like most of my patients do strive. They strive not to inject into muscle. And they don't even know the length of their needle. If you think back, if you say to your patient, what length needle are you using? A lot of your patients my patients, they actually hesitate and they're like, oh gosh, whatever's on the prescription, or whatever the pharmacy gives me. But then if you say to them, okay, well, what's the color of the top of the needle that you peel off? They can instantly answer if it's green, if it's purple, blue, or white. And that's interesting because, again, it's a visual. So this is why I use the slide with my patients when I'm educating them about injection technique. It's showing them the needle, that we don't want to go into the muscle, you just want to go into the subcutaneous layer. And I suppose my practice, I do prescribe 4mm needles, and I will discuss that a little bit more as we go on. I mean, skin thickness is roughly, I suppose, around 2.4mm. So you're only going into the subcutaneous layer, so it doesn't matter on your size, your weight. It's the needle length is also important, and ensuring that your patients have the correct needle length. It's better because it's less pain for them. Now, I will say the 4mm needles, they may not be suitable for patients if they have tremors or any other disorders where they're unable to hold the 4mm needle in place, and they may need a longer needle. But that again, it's individual and it's based on everybody's own practice, really. So again, this is just showing you, and again, this is another slide that I use for my patients. Again, it's just that little bit more in depth. You're showing your subcutaneous layer, you're just going through the skin. What I also like about this is the 90-degree angle, because it's important to promote that. You don't want them going in and then deciding to straighten up when they're in, and then it bends and it hurts them, causing pain, or they're bruising. And there's a lot of things that they can do that. It's especially pediatrics. I suppose I did forget to say I am pediatric and adult trained, so I see both. And when you're educating children, you're also educating the parents or the carers or the guardian. And then when it's adults or young adults, it's more those that you would be educating. But when you're educating the parents, for children, they're a good fallback for the child, because it's important for them to support the child and help them. Even though the child will be doing their own injections, it's important for them to supervise them, because they are children at the end of the day, and they just need that little bit of support while they're doing this. Moving on now to my next slide. This slide was one when I was doing up my presentation. I was like, oh wow, when you see it, I was like, oh, if you use an 8mm needle, you have a 15.3% chance of injecting into muscle. That's huge. Whereas if you use a 4mm or even a 5, the risk is so much less, like a 4, 0.4%, 5mm, 1.8%. So that alone is huge, and I do like this. I think it's something that I will use, because I don't know about you, but if any of your patients, they get used to using a certain needle, and sometimes they can be very reluctant or not keen to change their injections, their needle length. But when you show them something like this, then it's for them. It's the visual. It's seeing, like, well, if you're having problems with erratic blood glucose, and you're getting a lot of lumps, then possibly is it because your needle is too long? So that's a really important slide for me. And And then moving on, this is a question, I don't know about you guys, but this is a question that I get asked a lot in my clinic and even over the phone. It's like, do I need to, some people call it the pinch, some people call it skin fold. It's kind of a tough area because you don't want them pinching too narrow or folding too narrow. But look, my advice is that if it's a child who's very, very lean, then yes, they do need to do a skin fold. Absolutely. And to find somewhere where there's a bit of bounce. And what I mean by bounce is that you're not on like a bony prominence, or you're not like where they're really muscly, where you're finding somewhere where you can kind of just lift that little bit up. And that can be make a huge difference to that child, because as they grow, obviously the areas, there'll be a little bit more bounce in some areas, and they will be able to do their injections. But if they hurt themselves, or they're like injecting into muscle and it's constantly sore, well then I have found, and this again is through my own practice, that site rotation can be a major thing for them, and they get extremely upset if it's using a pump and moving their sites around. It can affect even children, MDI, whatever you're using, it can make a huge difference to them. So it's again, and I involve them when I'm teaching them. I get them to find where the bounce is. And it's good because, you know what, it's not me sitting there telling them all this stuff. It's me showing them, and they're involved. And when they're involved, they're more interested naturally. And they do get a little bit of fun out of it then, because they know exactly where to go and they like to show their parents. And again, young adults, again, I get them involved. I ask them, where do they think, and we discuss it. And it does work out really well. I find that my patients engage better after looking at this slide, and then with picking out their own sites, and then they can practice the skin fold while they're here, and then they identify if they need to do a lift or not. It's, you know, so I'm empowering them to make the decision, and I'm helping them and involving the patients in education. It allows them again to become active self-care managers in diabetes care, and they're empowered to make these decisions. Okay, so moving on to my next slide. Yeah, the potential consequences of poor injection technique. Again, I'm sure this is an area in your practice that you're well used to. So obviously your lipohypertrophy, your excess insulin requirement, inaccurate dosing, poor efficacy of your insulin, risk of a needle stick injury, and then reduced time in range. So if you have reduced time in range, and also other thing here is your hospital admissions, increased risk of complications. That's areas that we're striving to move from. If you have reduced hospital admissions, well then obviously it's a cost saving measure for if it's the NHS or the HSE, it does end up, I suppose, costing less, because you are admission avoidance, so you don't have to admit that patient for whatever amount of days until their blood glucose stabilise, and their control will improve, and you want to reduce the risk of complications. Time and range. This is a big, I suppose it's the buzz for me. With Dexcom and all the CGMs that we have, we use Dexcom, we use Medtronic, we use it quite a lot here. It depends on what the patients are suited for, and pumps. Time and range, you know, is so important. You can have good blood sugars pre-meals, but like you could be 15, 20 in between your meals, and it's the spike of the air underneath the clouds. And the amount of data that we have available to us at the moment is phenomenal. We are in I suppose, an age of technology. It's exploding. And we've never, up to say, like having these, like if you think back 6-7 years ago, we didn't have this information. It was the book, the diary, as my own used to keep when they came into clinic, and you just seen maybe 4 blood sugars a day. If they did 4 blood sugars a day, they may not have recorded their hypos, their highs. They may not recorded that they went like low in the middle of the night, or, you know, you were just able to base your practice based on what was in that book. Whereas now we have this phenomenal technology, and we can see everything for, like, you know, the 24 hours. It can help us guide our patients better. It can give them more, I think it gives them like a security blanket, because they have alarms. If they're going to go low and they are running tight at nighttime, their alarms do wake them up, and it is a safety net. A lot of parents will tell you that they can sleep easier knowing that they have an alarm there, and the children themselves and the adults will say, you know, that they definitely find that this CGM is great. For us as healthcare professionals, you know, we want to reduce the implications of poor injection technique, because you have unpredictable absorption. You can have rapid absorption, you can have poor absorption. So, I mean, your good injection technique it's crucial to achieve the expected absorption of and the action of the insulin. Yeah, we don't want a negative impact on quality of life. That's huge as well, because, you know, we want to promote a good quality of life for our patients, that they are happy, and that, you know, diabetes is, it's going okay for them. They're not too stressed. If they have, you know, erratic blood glucose, or, you know, hypos that just appear for no reason, it can be quite upsetting for a lot of people. And I would find that particularly children, because they can find, you know, and adults too, if you go to a party or you have an event or something and you're worried you're going to go low, it's that constant worry for them. So at least if we know that they're moving their sites and we have good injection technique, well then that works for them, and that's good. It's all about supporting them. Moving on to my next slide. So yeah, managing blood glucose and finding the right balance. And it's like, you know, if you think of diabetes like a wheel, and you want that wheel to turn, so it's made up of 3 components. So you have your exercise, your diet, your insulin. And obviously your insulin is major there, because you've got to go through the importance of injection technique, because it's the only way they're going to get their insulin correctly. It can make a huge difference to their daily blood glucose control, to their life. And I mean, insulin is and increase their time in range. All right, now, so question, moving back onto the lumps. What happens if we don't adjust the insulin when avoiding injecting into a lipo? So from what I have found, and based again on my practice, the reduction of insulin, it can be 20% or more, depending on the size of the lipo and the patient you have in front of you. I think we have to be, you know, mindful that not to be afraid to reduce the insulin, and to get that across for our patients that it's okay, you know, not to be afraid to reduce your insulin. And that dose adjustment may be required to minimize the risk of hypos, but that titration also needs close monitoring. So they may need to be in contact with you, maybe weekly or monthly, depending on what's happening. I think it's important for our patients to discuss this with us before switching to a different site, so that we can with them put a plan in place, so hopefully that we will avoid any erratic blood glucose control. We use virtual CGM clinics, we have virtual pump clinics, we have started bringing our patients back in on a one-to-one basis. So again, I'm now moving on again, kind of promoting injection technique. And actually, interesting enough, I had clinic last week, and 3 out of the 15 children who had come to that clinic had significant lipos. And now it was about 8 months since we'd seen them, because obviously with the pandemic, we had reduced down to virtual. And I had felt, I suppose in the start, I was a little bit disappointed. I was like, oh, how did they get to have such significant lipos? And then when I started talking through the parents, even though we had discussed it on the phone, they kind of felt everything was fine, but they didn't know how to kind of look out for it. And I will cover that a little bit more. So to answer the question, what happens if you don't adjust your insulin is fairly simple. It's hypos. And those patients, and I'm sure you've probably heard from your patients, you know, oh, I was just sitting on the couch and my blood sugar was like 1.8. Did nothing, had no idea why it went that low. I hadn't done any exercise, was actually having a day off, or, you know, there can be many things that they can say. And like I say, 20%, you may go 30, you may go 40. In some cases, we have gone 50% reduction, because it's again, through that kind of constant contact, maybe like a weekly basis. It's amazing how much that you can help your patients to avoid hypos, and then kind of titrating to target. So moving on from that, then, the advice to patients, I know as healthcare professionals, you all know this stuff, but I just wanted to, again, just show what I use in my practice. So we use the suspect, detect, protect from BD, and based on the FIC guidelines. It's our guide here. If you don't suspect it, you can't detect it. And if you don't palpate and look for it, then you're never going to find it. So this again is a nice, clear slide for our patients, and the next few slides are based on suspect, detect, protect. So here, just for yourselves, and it's a good to in your clinic, it's a good prompt if you kind of are sidetracked, because, you know, questions can come in, and like I say, it mightn't be the biggest problem. There could be something completely else, maybe it's exams, there's lots of stuff. So it's just if you hear, for me it is, if I hear the words like that, I had a hypo just sitting on the couch with 1.8, then automatically I'm kind of going, okay, so I need to ask myself, there probably is lipohypertrophy present, and then I try to explain to them and get them to look. If they're here, I can look myself, but it's just even asking the questions, where do you do your injections? Do you tend to go for that area all the time? Do you find your injections painful? Do you find that maybe you go really high after a meal? Just simple little questions like that can all lead to suspecting hypo. The other thing is, if they are telling you that their injection sites are not painful, then that does raise questions for me, because I do think a new site can be painful. So then they revert back to their comfort site. So it's trying to break that habit of them, explaining to them, if you're not feeling it, you should feel a tiny little bit, but if you're feeling nothing, then there possibly is a lipo there. So the questions I'm sure you can see from the screen in the pink box, consider asking your patients these questions. These are quite good. Everyday questions can be asked in a couple of minutes. Asking them, do they use their needles only once, and what size needles do they use? They might have to go off and get it, but at least they'll be able to tell you. So the tech then, when you're asking your patients to go and check for their lipos, they may tell you, you can nearly hear them like, oh yeah, no, I'm just going to look in my tummy, and they pull up their t-shirt and they're like, oh yeah, no, I look fine. But actually, if you ask them to spend a bit of time and to look, some of them may be visible to the eye, but some of them may not. And what I have here, we have a really, I know this will be quite difficult for you to see, but this is a tool that we use in our practice. Okay, and obviously one of the lipos you can see is it's quite obvious, but there's actually others hidden in this. And this is a tool that we have used for quite a while, and I use it in my when I'm delivering choice and merger. We use them here just to teach our patients about it, because they may not have a lipo, but to encourage them to keep rotating their injection sites, to not to reuse a needle, and to think about where they're injecting. And that box is actually really good, because there's some quite deep down, there's some bigger, there's some smaller, and when they all have a little feel of it, and they kind of realize, oh, okay, it's not, sometimes it's not visible to the eye, and you might have to use directional lighting as well if you're in clinic, because you can have a look. If they're sitting, you need to sit. If they're standing, you need to stand. It's for us just to be able to detect them. Sometimes if you ask the patients, maybe they need to stand in front of the mirror and look. They could do it maybe when they're in the shower or the bath, just kind of palpate their abdomen or palpate with their legs, wherever they're doing their injections, just to ask them, just to look at that and see how that is going. Okay, your hands-on palpation. You guys all know this. I know that I kind of feel that I'm telling stuff or trying to get across the stuff that you already know, that you're using your firm pressure. It's good to go through this regularly, and feel the difference in your tissue structure, and you will feel when you're palpating and you're rubbing and you're using that firm pressure, and when you come across your lipo, you do feel it's like the edge is kind of a harder ridge, or kind of a ropey feeling I do find sometimes. But you do need gel. I think it's really important that you use gel and use 2 fingers, and to sweep around and push into that fat layer. It's not kind of just gently rub, it's really get in there and really push down for them, just to try and feel it. And then when you do find it, I always ask the patient or the child to palpate as well, and for them to be able to feel it. And I think once they have done that, then they know what it feels like, and they know what they're looking for at home. Plus, they're more inclined to then look for it at home. Important to check all sites of the patients as well. They might just tell you it's their tummy, but they could be using their abdomen. They could be using their abdomen or their buttocks, or they could be using their thighs. So it is really important to go through all of that with them. And then my next slide is, now I know this slide is back in again. I really like this slide, obviously, but the reason I like it is it makes sense now as I move on to the next few slides, is that this slide, it's the recommendations where you're going to go, okay? And then it leads into nicely. So we're going to talk abdomen, thighs, buttock, and flanks. And it's injection site care for our patients, like the basic things: injecting your sites regularly, always wash your hands before you inject, avoid injecting into your lumps, and then don't inject through clothing. They cannot inject through clothing. No, there have been some people who have injected through clothing and it just doesn't work. So they do need to kind of take that on board. So yeah, this is why So what I do when I'm talking to my patients and I'm talking to them about their abdomen, I tell them to envisage the abdomen like a dartboard, and the belly button is the middle of the dartboard, and you're going to divide into 4 quadrants, and you're going to use each quadrant for a week. And within that quadrant that you move around, and you can see that on slide 2 on the second slide. So it's really important that they move around within that quadrant. And I think by using this method, what I find is it's easier to remember to move once a week. Whereas if you give your injection on your left this morning and then you don't remember where you gave it, you know, you can end up going automatically to the same spot, especially if you're left or right-handed, you will automatically go to what's more comfortable. But it's just to like not to use that for any more than a week. So, you know, they get a month out of their abdomen, and then each quadrant, once they move each week, each quadrant gets a 3-week break, and that allows the quadrant to repair itself, and it's rotating the sites. And it's the same for the legs, you know, dividing it down. You maybe use a leg for a week and then swap over to another leg, and that is really, really important. The other thing to stress to the patients is they'll say to you, you know, how far from your belly button? And I can say, oh, you know, maybe 1 centimetre. And they kind of look at you and they're like, oh, centimetre, depending on the age, of course, a centimetre. So what I kind of say to them is maybe a finger space from your belly button, and move around. And in making sure that your injection sites are finger space apart. That's something they have. They don't have to go worrying about rulers or wondering what a centimetre is. They can use it based on their finger, and they can move around within that quadrant. So just to move on to my next slide, then the detect, protect, prevent. If you inject into a lipo, the insulin's not going to be absorbed, or may not be absorbed in the way that they think it's going to be, which results in the hypo and the hyperglycemia. And it can be very frustrating, especially if you have somebody who's really working hard, you know, trying to maintain their A1C or get their A1C down, or, you know, improve, maybe they're exercising. It can be really, 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 really frustrating for them. So by rotating the sites and using the needle each time, you know, you can reassure the patient. I did have somebody before who did say to me that they'd use their needle for a day or 2 before they changed it. So I showed them this next slide, and I was saying to them, well, you wouldn't use a blunt pencil. And then once they've seen what happens to a needle once it goes through the skin for the first time. Now, again, I know this is a BD slide, but this is what I use in my practice. I like it. I like it that the visual of the needle, that it's been used. And so, you know, they wouldn't use a blunt pencil. So it's really, really, really important to get across to our patients that they must change their needle every single time. Their injections will be less painful. And the other thing is that if you reuse your needle, that needle can get blocked, and then they're not going to get their insulin. And look, once the needle goes through your skin, it's contaminated. You don't want to damage your skin, and it's less reducing the risk of developing lipos. Now, I put this slide in next because the test shot, I don't know about you guys, this again is something that I teach my patients every single time. Some people call it test shot, some people call it ear shot. I suppose each their own. For me, we call it the test shot. And I like this slide because it's important. We always say dial up to 2 and then squirt it into the cap. See if the insulin is actually coming out, because if the insulin is not coming out, then your pen may not be working, or have you reused your needle and is it blocked? Because you may not get your insulin that you think you're going to get, which again then can lead to erratic blood glucose control. And then now, just moving on to my next, I'm nearly finished, you'll be glad to know. I think I've been talking quite a while, sorry. I put in this slide with permission. So this, to me, I kind of looked at it first and went, oh yeah, it's not too bad. You know, it's okay. I think I see a slight lipo. But then I changed the lighting and I changed where I stood. Now you can see in the bottom right-hand side for me there's quite a significant lipo there. But again, it just shows you the importance of the angle that you're at, your lighting, that you're using your gel, that you're palpating around, that you can find these lipos and help your patients find them so that they know what to look out for. And finally, you'll be glad I'm at my summary. So really what I wanted to do was just raise awareness amongst yourselves, healthcare professionals, and then for us to be able to pass this awareness on to our patients with diabetes. We want to promote the best injection technique, and that's where you can refer to the Injection Techniques Master Guide. I put that in, that's what we use, but you know, based on your own practice in your own area, you may use other things. I want to encourage healthcare professionals, people with diabetes, that examinations of injection sites becomes part of your regular practice. If you do it every day, then it's in your brain, it's your train of thought. I suppose it's important as well that you document any abnormalities in the patient's notes, because you will forget, because you have loads of patients to see and you may not remember that. So it's good to have it documented for the next time. Showing our patients how to examine their own injection sites and to do so regularly. I suppose when I wrote that, I kind of went, ooh, what's regularly? Weekly. I think they should be checking injection sites weekly at home, and then obviously when they come into clinic. And it's important for them to be aware that the injection sites, if they develop lipohypertrophy from not rotating their injection sites, it could be that site can last weeks, months, or even years, depending on what the size of the lipohypertrophy is. Asking our patients to avoid injecting into areas of lipo until this tissue returns to normal. Oh yeah, there's the weeks and months, or months and years. Report any abnormalities, and discuss with ourselves before switching to different sites, because the dose adjustment. And then finally, just to refer to the FIT guidelines but that's what we do in our practice. And it's really, this is just an overview of what I strive to do in my practice. I think I've highlighted my concerns with the pandemic and us not been seeing our patients as much, and it depends on your clinics, and clinics can be really, really busy, but just taking that 3 to 4 minutes just to start educating our patients all the time on injection technique and rotating their injection sites can be absolutely amazing. And obviously never to reuse a needle. Thanks very much.
And we have got some questions in the chat box as well. So first question in the question box is the benefit of changing from human insulin to analog if injection technique, etc. is all checked out, but still small lumps at the site.
Yeah, that's I suppose what I have found is, yeah, we do have some patients who would have little lumps even from it, but what I would say to them is just avoid those sites where there's any sort of a lump. You do have to, I suppose, if you change the site, you're hoping the lumps won't appear regardless of the insulin. It's kind of a tough question, but what I say is that what I found is from my own patients, again, this is all based on my own practice, is that by them completely avoiding that site and then never reusing the needle and using a 4mm needle, definitely it has reduced. We did have somebody who had quite significant lumps from injecting insulin, but it just meant that they were on fast acting. It just meant that we just moved to a 4mm needle and he avoided that area for a month, and fingers crossed nothing has happened since.
Right, that's great, thank you. So next question is there any advice if injection site areas are reduced due to, for example, stomas?
Again, it's rotating your injection sites. For me, this is what I think, because there are quite a amount of people out there who do have stomas. So as I was saying, in Ireland, we don't use the upper arms, but we use the thighs, we use kind of around the side. And if there's somebody at home that they can do the top of their buttocks, that might be something if somebody is there to help them. You don't want to take away their independence, but if their injection sites need a break maybe for a week or two, it might be something to consider.
All right, that's great, thank you. I can see some questions coming into the chat. I will try and get to them, but to make sure that we get them answered, if you could answer them in the Q&A box, then I'll make sure that we can get to them. Thank you.
Okay.
What are the precipitating factors for its occurrence, like the amount of insulin, temperature of insulin, if it's kept in the refrigerator and not used at room temperature?
I think, and this is kind of what my cohort of patients have reported back to me, that if you keep insulin in the fridge and you inject it straight away, they get a sting because it's very cold. But from my experience, it hasn't increased lipohypertrophy. What increases the risk of lipohypertrophy is when they inject in the same spot and they don't change their needle each time. The amount of insulin, the insulin pens now, if you have patients who are on bigger doses, there is more concentrated insulin, so they can give the same amount of insulin just in a smaller amount. And I think that will help as well as we move towards avoiding developing lipohypertrophy.
Okay, perfect. Someone's asked if you are able to share your MDT template.
Yeah, that's the purple clinical book. Yeah, I can certainly ask for permission to share it. Yeah, that's no problem.
Thank you. Have you got any good tips for older patients on insulin with unsteady hands, causing lots of bruising despite using two-hand injection technique?
I found a 5 millimeter needle works better with these patients because it's just that little bit longer for them. One gentleman actually in my clinic yesterday, he has quite hard arthritis in his hands, but he was trying to do it one-handed, but by actually going to the second hand, it made a huge difference. But again, that's only happened yesterday, so as I go forward, I'll know that. I don't really have, just the bit of a longer needle is the only thing that unless somebody else may have a better answer to that question.
Thank you. If anyone does, then feel free to use the chat box to share. What patient literature do you use for promoting site rotation?
So I use a number of different literature. So I really do like the FIT guidelines. It's what underpins our practice, and that's what we base it on. But I do know the different companies. I know Becky, this Sanofi, they all have really good cards that you can give your patients depending what insulin they start on, and they do injection, like how to get your test shot, how to put your pen together, do your test shot, the importance of not reusing the needle and rotating your injection sites, and they all have really good, it's very clear literature, it's very easy for the patients, and it's widely available. If they don't take the card from you, they can Google it and up it comes.
Perfect, thank you. So where did you get the mannequin from for showing the patient lips areas?
Oh, I'm not promoting anybody, but we did buy this BD product. Sorry, it's BD Lipo Box. That's what it's called. We have 2 of them, and they are so essential. Like, they just are brilliant, really, really good. So I think I don't even know where they were bought from. Sorry. I know our rep from BD purchased on our behalf.
Thank you. So was always told to inject below the belly button, as if smile under the umbilicus, and also lateral aspect thighs, buttocks if others injecting.
Inject below the belly button. My first thing is like, oh no, it's too sensitive there. That might be a little bit more tender than if you kind of move to the side of the belly button. I mean, it's whatever works for your patient. It's going to be so individualized. And that's what diabetes care is all about. It's so individualized depending on what patient you have. And I would never, like, if that's, people do that, and that's fine. But for I don't really. They do a little bit, but it depends on how tender it is for them. Yeah, lateral aspects of the thighs, yeah, nice. They really have that kind of a little bit of a soft bit. Seeing your trousers as a guide is always a good little thing that I tell my patients. Because again, I want to give them things that they can use when they're out and about, when they're in the real world, not trying to, I suppose, measure. You want to do like everyday stuff. Make it easy.
Yeah, absolutely. Thank you. So someone else has asked, what is the reason that arms are not recommended for injection sites in Ireland?
I actually don't know that one. We've never really used the injection sites. Like I say, when you look up the diabetes care in Ireland and the fit form for injection technique, and I'm going through it here looking, and we just have never used the arms. It's based on, I think, on our model of care, and that's the way it's been through here. So actually, I don't have a really good, but I can come back to you on that one.
Okay, great, thank you. Is there a way to rotate within these diversions or quadrants of the site? Is it useful to go clockwise or zigzag?
You know what I actually do say to my patients? Ask them, are they left or right-handed? And then see what way they naturally go, and go with the natural, because that is what is going to, it's good. That's what they're going to do. It's go what suits that patient. That's the best advice I can give. And then I suppose I do kind of say to them to go 1, 2, 3, 4, or 1, 2, 3, 4, because it's natural, either clockwise or anti-clockwise, because if you're going up, back, or zigzag, you're going to forget.
Okay, perfect, thank you. What is the treatment if it is diagnosed?
So depending, I suppose that's where you have to look at your blood glucose control. Do they have CGM, or are they just finger pricking? You have to take all that in, and then depending on the size of the lipo and how high or low the blood sugars are, I normally would start with a 20% reduction and ask them to move their injection sites completely. The other thing I do ask the patient is, after they move their injection sites on night 2 or 3, if they could check a 3 a.m. blood sugar just to see how they're going overnight, because at that stage your reduction in your insulin has really, really kicked in, and they need to be able to see what is their blood sugars. Are they kind of dipping down maybe towards the 4.1, 3.9, or are they okay, or are they waking every night with hypos? You know, again, it's a very patient-specific question. It just depends on the severity of the lipo.
Okay, that's great, thank you. So the next one is, I've had a few patients saying that by using a 4mm needle, they find that the insulin comes at the surface, therefore they prefer longer needles. We advised the 4mm needles, but I couldn't really argue with those few patients reporting the above.
That's very fair enough. You know, it's very, what I do say to patients is, so, and I'm sure this is probably what everybody does this, but when they push in their insulin, they keep their thumb on top and they count to 10. And we have found then that the insulin doesn't come to the surface because that 10 seconds is buying, the insulin's able to be absorbed in. But I mean, if it's coming to the top of the 4mm, then try a 5mm. You still have a much greater risk of injecting into muscle by using a 4 or 5mm as you do, as opposed to like maybe using an 8mm. And I think that goes back to one of the slides that I had done about the like the risk of injecting into, it's the intramuscular risk. If you use an 8mm needle, it's 15% chance of going into muscle, whereas if you use a 5mm, it's only 1.8. That's quite a low risk. So I would say, yeah, that's fine. And again, patient specific.
Okay, wonderful, thank you. Someone said, apologies if you've already covered this, but how much is too much injection in the same site?
Ooh, how much is too much injection? Well, I suppose, again, patients for here in Portlaoise are probably on maybe 5 to 6, if they're MDI, 5 to 6 injections per day. A lot of them prefer to do their long acting in their leg if they haven't been doing sports, and then they'll use their abdomen for their short acting. I do find patients who maybe are on mixed insulins, they prefer to do the abdomen. I don't know if there's if I could ever put a number on, like, I suppose the frequency is, you know, don't use it any longer than a week. After a week, move. And if you keep doing that, then you should be fine.
Okay, perfect, thank you. Do you have any resources available that would be suitable for encouraging site rotation in paediatrics?
I know BD and do have like some of the slides I used just for pediatrics, that visual, the slide that I put in twice about the injection sites and rotation, that I find in the pediatric land, they like it because it's colourful, it's a very clear visual, so it's the where to inject slide. But I'm sure if you contact your rep, and I know they'll help you, they'll get the bits and pieces to you. Yeah, that's really the only thing I use in pediatrics, because I suppose when you're teaching both the parent and the child, you know, and you're getting the information, the parent kind of reaffirms what you've said, and they kind of, it takes a little bit of time, but they do eventually kind of know that they have to rotate their sites.
Okay, that's great, thank you.
There is one question about the Omnipod. I actually don't have any experience of Omnipods, and they're not available in Ireland as of yet. So I definitely wouldn't be qualified to, I suppose, answer the question on the Omnipod. Sorry.
Perfect. So someone said, thank you so much for the informative practical lecture. You talked about lipohypertrophy, but what about lipohypertrophy?
Could I come back and answer that one? That's a bit of a long one for me. Is that okay?
Yeah, of course. So someone has said, I wouldn't use arms either, only as a last resort, more chance of hitting muscle than subcutaneous tissue. We also use abdomen like a clock face and rotate around as long as away from belly button. Your advice is great.
Great.
Great. So I'm just going to have a quick check on the chat box to see if there's any final questions. Someone's written, there's big issues with teenagers. Any pointers as they are creatures of habit?
Oh, they are creatures of habit, eye rolling, tutting at you. Sometimes I even find myself, I eye roll back at them if there is a lot of eye rolling. And they're like, from what I find is, teenagers, you just have to go with the flow. And it's non-confrontational. I'm like, well, what do you think is going to happen? And I try to put the ball back in their court, because I'm like, this is your diabetes, this is your injection sites. Do you want these lumps in your tummy? And when it comes to summer, they definitely don't want the lumps in their tummy. So it's by just, again, I suppose it's empowering them, because sometimes what you'll find is if they've been diagnosed quite young, that a lot of the information goes over their head, whereas when they come to their teenage years, they might actually need to be re-educated. And I have done that on a few occasions, and it has actually worked quite well, just by re-educating them and kind of helping them understand the importance of moving their sites, not reusing the needle, and that the benefit is for them. And that's really where we want to go. Like, it's all about them.
That's great, thank you. So the final question that I can see in the chat box is about breath. You mentioned from the umbilicus. They've just asked if you could repeat it again.
Sorry, say that to me again.
So a question about finger breath. You mentioned
from
the umbilicus.
Yeah, so if you think of the abdomen as your dartboard, and the umbilicus is the middle of the dartboard, so you're just dividing into 4. But when they come around where their belly button is, or the umbilicus, it's just to use your finger, just a finger space, and then inject on the far side.
Okay, that's great, thank you. So someone has come back to the final question in the Q&A box. So hopefully that's answered that question.
Okay.
Thank you. Becky, did you have anything to add? Any other questions?
Just Georgina, is it worth just sharing how you're encouraging people when you're having a virtual consultation with them to check for their own fatty lumps, and any tips or tricks you've got around supporting them, not seeing them in clinic, how to palpate, that type of thing?
Yeah. So again, I get them to go on to Google, because they love Google and they love YouTube. And if you have teenagers or kids, YouTube knows everything. And I'm sure you've all heard that before, and it does sometimes. So what I found is by kind of looking up different sites for the guys to look up themselves, and again saying to them, well, if you have a look, I've had a look at this site, what do you think? Do you think it'd be good? And then they'll come back to you, they'll go and they'll look at it. And then again, it's a visual for them. And it could be that you're talking them through it on the phone. Like I said, I have asked them to stand in front of the mirror, put some gel on their hand. If they tell you they don't have gel, I get them to get some, even a moisturizer, anything that they're going to be able to create. And just talking, it's just really, you've been very clear and concise in what you're asking to do. But the standing in front of the mirror in the daylight actually is quite a good one. And then looking on Google, looking on YouTube, using these resources that are available to us. Now I do know that there's some forums as well out there on Facebook and a lot of things, but like even, you know, going into the likes of your Sanofi site, it's all there for them. It's so readily available. And they, as I just say, the teenagers in particular and young adults, their phone is never out of their hands, so it's a quick flick on Google and they can see exactly what to do.
Yeah, I have seen a really good resource from Leicester Diabetes Centre, which is a little cartoon on how to check fatty lumps, which is quite nice. That's freely available on YouTube as well.
Yeah, and I think if it's in a cartoon form as well, I think again it's that visual thing, because it's not like it's stuffy, you know, that you're coming in, you have to do this, or it's not like an exam. It's fun, and that's what they want, is to make the fun element.
Yeah. Someone's just asked while we're talking about that, about what benefit you think the gel has for them using.
I think you palpate your lipo so much easier with the gel. If you don't use the gel, you can actually miss it. Whereas when you have the gel on and you're kind of palpating across, you'll feel the edge nearly instantly. It just makes it easier.
Okay, that's great. Unfortunately, that is all we've got time for today, but thank you so much, Georgina. That was really insightful. We've had lots of messages coming through, and thank you very much, Becky. So finally, before we go, I'd just like to thank Sanofi again and BD for kindly sponsoring the webinar. Thank you very much.
Thanks, everybody.